Hello, I'm Andy Rosenkrantz, Editor-in-Chief of AJR, and I welcome you to our next AJR Forum. This event is being live streamed on multiple social media platforms, and the recording, along with a transcript, will later be published in an upcoming issue of the journal as a multimedia article. The topic for today's forum is opportunistic screening. The high utilization of CT creates an opportunity to leverage the acquired images to provide additional insights beyond those directly related to the stated indications. For example, CT data can provide info on bone mineral density, vascular calcifications, hepatic steatosis, muscle quantity and quality, and other markers. These can in turn be used for prognostic modeling to predict future health outcomes as supported by a good volume of emerging data. Moreover, AI has enabled automated tools for performing opportunistic screening at large scale. Nonetheless, challenges remain, including the need for testing in broader, more heterogeneous populations, understanding the added value relative to existing models, and solutions for workflow integration. These issues will form the basis for today's forum. With that, I'm delighted to introduce our host, Dr. Kirti Magudia, Assistant Professor of Radiology at Duke University School of Medicine. Dr. Magudia, we thank you for being here and leading this event today.
Thank you, Dr. Rosenkrantz, for the opportunity to host this AJR Forum. Thanks also to all those joining us from multiple platforms for this AJR Forum to highlight the important topic of opportunistic screening. Opportunistic screening is screening that depends on requests from patients or providers and takes advantage of when a patient presents for care for another indication. For example, this could be when a child undergoes vision and hearing testing at the pediatrician's office for a well child visit. This contrasts with organized screening that's coordinated by the public sector, such as vision tests performed in schools. Opportunistic screening in the radiology context could be taking advantage of a CT scan that a patient undergoes during an emergency visit for abdominal pain to inform a patient's cardiovascular risk. To provide all of us with insight into the fascinating topic of opportunistic screening, we have a panel of esteemed speakers. Please feel free to put questions in the chat, and we will do our best to answer them during the session. I would like to introduce our first speaker, Dr. Michael Rosenthal of Dana-Farber Cancer Institute and Brigham and Women's Hospital. He's an assistant professor of radiology and the assistant director of radiology at Dana-Farber and Brigham and Women's Hospital's Pancreas and Biliary Tumor Center, and he's also an investigator at the Hale Family Center for Pancreatic Cancer Research. The title for his talk is Muscle, Fat, and the Pancreas, Hope for Opportunistic Screening. And we are in for a treat as Dr. Rosenthal will be able to demonstrate the role of radiology in the future of biomedical research, synthesizing his clinical expertise with his formal background in computer science and strong collaborations in oncology. Thank you, Dr. Rosenthal, for joining us.
Thank you so much, Kirti, and thank you everyone for joining this evening. It's really an opportunity to share some enthusiastic developments that have happened in the last few years in pancreatic cancer. We don't often get to say great things like that. So I'll talk about muscle, fat, and the pancreas and our hope for opportunistic screening. So pancreatic cancer screening has been a grim area. Pancreatic ductal adenocarcinoma, the most common kind of pancreatic cancer, represents about 3% of the US cancers, but 7% of the US cancer deaths. It's an extremely lethal cancer. That's primarily because 80 to 85% of people present at an advanced stage. And when presenting at an advanced stage, the median overall survival is less than 12 months. Right now, there's no effective screening program for the general population. There's no screening recommended for the general population. We do have screening programs like CAPS for high-risk individuals who have familial or genetic histories that predispose them developing pancreatic cancer, but that doesn't extend beyond these very limited high-risk groups that represent less than 10% of all of the pancreatic cancers. This is really a perfect opportunity for opportunistic screening if we can find an appropriate biomarker. So the general strategy that the pancreatic cancer community is approaching to general population screening has been risk enrichment. And this is a great opportunity for AI to step in and give us some insights. So in the general population, the annual incidence of pancreatic cancer is about 13 per 100,000. And there's really just no screening test that can function at that kind of prevalence. But we know that screening is effective and saves lives in the high-risk population at an incidence that's closer to 1 per 100 or 0.5 per 100, depending upon which cohort you're talking about. It's 100-fold risk intensification there. What we want to do is to identify high-risk subgroups in the general population that have the same kind of intense risk that our known familial and genetic groups do, and then actively screen them. And the strategy here generally is to use low-cost, low-risk AI-driven techniques up at the top where we're closest to the average risk pool to basically filter out as many of the low-risk people as we can. And as we move down these layers of the filter, we move from really cheap tools like EMR analysis and opportunistic analysis of images that are acquired for other purposes to more intense things like blood testing, stool testing, and direct surveillance. Our goal, again, is to arrive at this high-risk pool and then actively screen them. So where do we stand in moving down these filters? Well, one of the first ones that I was involved in was related to muscle loss, and I'm going to talk a little bit about that. So why muscle? Well, in 2014, my colleague Brian Wolpin was doing a study of blood samples from the Nurses' Health Study, and these people had had blood drawn every 2 years. They looked at the subset of people who developed pancreatic cancer and looked back at their blood samples and compared them to people who didn't develop pancreatic cancer. And what they found was that there was a significant increase in branched-chain amino acids in the blood samples. It's difficult to understand immediately what that was, but when they went to mouse models and tried to trace these branched-chain amino acids, it became clear that in mice that had a very high rate of development of pancreatic cancer, that these mice had muscle breakdown compared to the healthy controls. And so muscle seemed to be the source of these branched-chain amino acids. The question was, how does this happen in human beings? So I got involved at this point, and we started looking at whether this did happen in human beings. So we looked at a group of about 700 people who were recently diagnosed with pancreatic cancer. And we manually measured the muscle and fat on every one of their CT scans at diagnosis. And we found that about 2/3 of the people had low muscle mass, which is called sarcopenia, at the time of their diagnosis. And interestingly, about 1/3 of them were sarcopenic and obese. And so they wouldn't have had external signs, cachexia. This isn't the advanced wasting syndrome that we usually think of. These are people who are overweight, but have lost more muscle than would be expected in their situation. And this was a poor prognostic indicator. If people continued to lose skeletal muscle during treatment, they survived less. And so this was the group that had the highest degree of loss, and their odds ratio for death was about 2-fold higher from the baseline. So what this data showed was that muscle wasting is happening in pancreatic cancer patients and that it is clinically impactful. So it took me about 2 years to measure all of those CT scans. We decided to move on to automation, and this was around the time that convolutional neural networks were being developed. We developed a convolutional neural network to automatically identify and measure muscle and fat from abdominal CTs. And these charts show a comparison of a fully human analysis versus a fully automated analysis. You can see that in subcutaneous fat, visceral fat, and in muscle, there was really excellent correlation with ours of about 0.99 for all 3 of these compartments. And we did another study where we compared the automated system to human readers, and we could not distinguish between the human and the automated readers at a 5% threshold. So this showed that we could do fully automated body composition analysis. The next step was to think about how we could do this in bigger populations. And so Kirti Magudi and I worked together to define a population reference set. We analyzed a little over 12,000 CTs from people who did not have a cancer diagnosis or a major cardiovascular diagnosis around the time of their scans. And what we found was that across sex and age groups, there were really significant differences in the distribution of muscle and fat. And so we can see here, this is the median, and these are progressive quantile curves in either direction. These curves were not linear, which is really important because up until this point, many of the risk models that have been developed using body composition used linear age corrections, and this showed that that would not be effective and in fact could cancel out age effects. It's fine to do that kind of analysis when you're talking about population studies and saying, asking questions like, is there an effect here? But when we talk about individual risk inference, you want to look at one person and measure their risk, we can't do that. And so we developed individual z-scores using age and sex indexing, and that produces age and sex invariant metrics for individual risk calculations, and that was really beneficial. We moved on to looking at a pre-diagnostic cohort with our friends at Kaiser Permanente. We looked at about 900 cases and 3-to-1 matched controls. And what we found is that the people who are going on to develop pancreatic cancer, and 0 is the date of diagnosis, had progressive wasting of muscle as we move back in time from their date of diagnosis, whereas matched controls had none. So this shows that not only is muscle wasting present at diagnosis, it is leading the diagnosis of pancreatic cancer by at least 6 to 18 months. And this was the greatest lead time. We also looked at BMI and fat areas, and those happened later on in the process. So now we know that muscle is important, it leads the diagnosis, and we're trying to figure out if we can use it as opportunistic screening. Well, one important question was, does this make sense? Is there a good reason? And we had seen before with the mouse models that exocrine dysfunction seemed to be an important driver of muscle wasting. Recently, another group, Suresh Chari's group from Mayo, showed that when we have new onset diabetes, which is a common association with pancreatic cancer, that those people developed significant risk intensification for pancreatic cancer within the 12 months after their diagnosis. And so we can see that fully 60% of the incident pancreatic cancer cases within 3 years happened in that first 12 months after a diagnosis of new onset diabetes. And this again aligns with what we're seeing in muscle. So endocrine and exocrine dysfunction of the pancreas all happening in this kind of 6 to 18 month window. Radiomics has been very exciting lately, looking at the texture of the pancreas. And we've also found, in addition to groups from Cedars-Sinai and Mayo, that radiomics signals in that 6 to 24 month window can be predictive of future pancreatic cancer. This is a paper that we're working on right now that shows that while we get a positive signal for pancreas, the addition of other organs, including the liver and muscle and fat, actually improves our ability to detect pancreatic cancer early, up to an AUC of about 0.73. All of these are showing that there are changes in the pancreas, it's affecting endocrine and exocrine function, and it seems to lead the clinical diagnosis by somewhere around 6 to 18 months. So what are we going to do to get to clinical implementation? Well, we've got to work through the biomarker pathway, and this is the NCI standard phases of biomarker development. We've gone through phase 1 and 2 with assay development. We're really in the end portion of phase 3, where we're looking at retrospective longitudinal data. Right now, we're working on defining what the screen positive rule is there, and then we're going to move on to prospective screening. And phase 4 and 5 are where we're really talking about clinical implementation. We've recently done an analysis of paired CT data, looking in the healthy population, looking at what these changes are. And what we found was that there's relative stability of these body composition metrics over time, even with up to 5 years between the exams. We're now working on defining a fixed action threshold so that we can differentiate people who have normal background variation from people who have clinical events. And we've also looked to see if this is impactful. And in fact, the people who have the greatest degree of loss, minus 1.5 z-score units, have significant declines in their overall survival from all causes that extends out at least 5 years. So now we're defining this action threshold, and we're also working through the competing risks, the other diagnoses that are associated with these positives. Prospective validation is the next big step, where we have a study open right now where we're recruiting patients who meet the NCCN high-risk criteria to an enhanced screening protocol. which is a CAP-style annual MRI and endoscopic ultrasound as backbone. Then we add in Q6-month blood draws. We are returning results from hemoglobin A1C and CA19-9 kinetics to align with data on new onset diabetes and some of the indications that CA19-9 kinetics may be useful for early detection. We're also doing research-only analyses of imaging, including body composition, EMR, stool, and novel blood biomarkers. This is really a framework for conversion to prospective evaluation as these biomarkers move from phase 3 to phase 4. So the vision for success is to build on what we've already done with CAPS and high-risk cohorts, do enhanced screening that will incorporate blood biomarkers, metabolic assessments, MSED assays, organ radiomics, and EMR risk, but also to fold in this new opportunistic screening using imaging biomarkers and EMR risk models so that we can have this enriched risk cohort from the general population that we screen, find early detection, and cure. Thank you so much for your time.
Thank you for that excellent presentation, Dr. Rosenthal. And I saw that you were talking about how there are high-risk populations that do undergo screening by imaging. Do you think that there could be a combination of using imaging-based biomarkers such as body composition in that particular group, the high-risk group that's already being imaged?
We don't know if it's going to work in that group. We don't know if the biology is exactly the same, but we're engaged in the study now to try to find out. If we are able to see a risk signal in this population before the clinical diagnoses, and there's room in that kind of high-risk screening to improve on early detection, then we would convert that over to a return of results study, and we would find out if, in fact, we can find these cancers that aren't yet visible on the MRI and endoscopic ultrasound that's happening. That'd be wonderful if we'd save more lives.
Yeah, excellent. Thank you so much. So we're now going to next hear from our second speaker, Dr. Perry Pickart of the University of Wisconsin. He's the John R. Cameron Professor of Radiology and Medical Physics and Chief of Gastrointestinal Imaging. The title for his talk is AI-Driven Opportunistic CT Imaging, the UW Experience. I'm excited to hear Dr. Pickart's presentation, given the breadth of his research in the domain of opportunistic screening with a range of applications and a long-standing collaboration at the NIH. Thank you.
Thanks, Gertie. It's a pleasure to be a part of this forum. As you mentioned, I'm going to be kind of giving a broad strokes overview of what we've been doing at the University of Wisconsin in this area. As we've already heard, we know opportunistic screening is essentially leveraging this information that typically goes unused. And some people bristle at the term opportunistic, and I think we typically will add value added to the beginning of that to kind of soften that. And of course, there are some other terms that could be applied, but I think we're stuck with the terminology, and obviously opportunistic screening is a term that existed before all of this, specifically with imaging. And why are we talking about it now? It's kind of a convergence of a number of things, but most importantly, I think the explainable AI solutions that have come to light now have really given energy to all of these other things that have pre-existed. The generalizability of CT, for example, the large, massive volume that we do, and all of these scans are therefore retrospectively available with built-in follow-up, so we can do amazing things in terms of predictive models. We can actually test them immediately. And of course, this is all about personalized medicine and adding value to what we're doing. So I think this precision approach really fits in nicely. Just broadly, I think we all have a concept of what this is now. It's basically taking any CT scan done for any reason and extracting various cardiometabolic biomarkers and so forth, some of which are quite valuable, and we'll get into that a little bit. This is our current pipeline. Just what's nice is, at a glance with these QA images at a couple of different levels, L1, L3, and then this coronal MIP, I can tell within seconds whether or not this is an acceptable scan at the patient level, the individual patient level. But of course, we also have large scale research. We're able to, get through tens of thousands of patients scans a day, or even more, obviously, depending on your compute power. And just to show the generalizability, these are examples taken from scans from companies that don't exist anymore, like Marconi in the upper right here, or dating back to 25 years ago. You can see over time, it's just CT is a very stable technology, and there's kind of a single lens, so to speak, unlike MR with all these different sequences and so forth. So it's really a versatile and with the high volume, the perfect test to be using for this kind of opportunistic approach. There's so many ways things we've looked at that I could talk about, lots of different directions. I'll try to just focus on a few of these things in the limited time, but I would like to make a note that this is separate from the somewhat related topic of incidentalomas. This is a very different approach, and it's more of a glass is half full sort of thing, if you will. And starting with biomarkers for osteoporosis, of course, most directly that's bone mineral density, and CT does such a direct volumetric approach towards bone density as opposed to the planar DEXA, and I think people are becoming fully aware now of the potential for CT to be opportunistic screening tool for osteoporosis. So that we've kind of demonstrated that repeatedly. Here's just a patient example. This was a patient at 75 years old at the time of this initial CT. Undergoing CT colonography screening, but it could have been any test, I suppose. Already has low bone mineral density. Anything under 90 Hounsfield units, they'll have an increased risk for future fracture. That's kind of the optimum threshold. But you can see 5 years later at follow-up colorectal screening, we're now dropping even more. We're well below that 90 Hounsfield unit threshold. A couple of years later, had a CT for some other clinical indication, and now you can see we're actually getting compression fractures. So now this is complicated osteoporosis. Many of these things still go silent, but this is obviously this should set off alarms for patients at risk for more catastrophic things, such as the hip fracture that happened later this year after this last CT. And looking back, this is something we could have probably prevented. And hopefully some of these cases won't go undiagnosed if we start to harness this information. Just another case, another patient who was only 59 at the time of this scan, has pretty severe osteoporosis, but also has myostenosis, which, as I'll show you, put her at increased risk for hip fracture as well. That happened 3 months after the time of this CT. And muscle density alone, myostenosis, does just as well as the multi-variable FRAX measure for predicting hip fracture. So we can we can model things by incorporating not only bone mineral density but also muscle and certain fat measures. And actually, this patient, just to get back to the opportunistic angle, had scans many years earlier for urolithiasis, and we should have noticed that she went from osteopenia to fairly severe osteoporosis, and this is now several years out before she had that hip fracture. So lots of time to intervene. So that's kind of one take-home point. Changing gears a little bit, Michael talked about sarcopenia already. With most of the outcomes that we're predicting, we find that muscle density, or that myostenosis, is a much more stronger biomarker than the amount of muscle myopenia. So muscle area is less valuable to us, but and this is just a graphic to show these are healthy screening patients, and you can see after 10 years out from an initial CT scan, quite a difference between those that have that lower density muscle, which is a marker for just general badness, honestly, versus muscle area, which really has some signal, but not nearly as much, in part because things like diabetes actually expand the muscle. And so it doesn't necessarily mean healthy if you have more. It can be fatty muscle. So those things need to be taken into account. In terms of cardiovascular disease, Ross, Felice will talk more about coronary artery calcification, but we've been having great success with aortic quantifying aortic calcification. You can see in this upper graph here, these are different quartiles of aortic calcification predicting future cardiovascular events. Does better than the Framingham risk score, which has a little bit of confusion amongst the various quartiles. And this is just a single automated measure. So it's really, the potential is pretty obvious, just like it is with coronary. And one nice thing about the aortic tool is we can use post-contrast portal venous phase scans. So that, that's about 2/3 of all the abdominal scans we have. So we're not just limited to non-contrast CT. So that helps the opportunity there. In terms of diffuse liver disease, we have fatty liver disease, but more importantly, we want to identify those patients that go on to fibrosis, because that's really what drives mortality in fatty liver disease, as well as other chronic liver disease. This patient here had metabolic dysfunction associated liver disease, but also alcohol use, and that really potentiates things. So from this initial CT, where you can see an enlarged fatty liver, there is some evidence of segmental redistribution, so possibly some fibrosis likely at that time. But 4 years later, this has accelerated to pretty obvious cirrhosis with F4 level fibrosis, and this is the kind of thing we can successfully screen for. We've been doing it retrospectively in a large scale, but we can do it prospectively with individual patients. Just another example here. This is a patient who just had MASLD without the alcohol overlay, and so typically this plays out a little longer, but without going into detail, this patient already has some degree of segmental redistribution, with segments 1, 2, and 3 are a little bigger ratio-wise to segments 4 through 8. Spleen was normal size at this time. 3 years later, that volume ratio is getting more abnormal, more segmental distribution that implies underlying fibrosis, could be significant F2 or advanced F3, but also splenomegaly starts to intervene even before cirrhosis. The spleen gets a little larger in some cases. You can see it took a long time to play out here, but 18 years after the initial CT, this patient now not only has cirrhosis, but presented with a complication of cirrhosis, had multifocal HCC with tumor in vein invading the portal vein. And so, again, this is something we can easily detect at a much earlier stage, and there's a very broad window for detection of some of these chronic liver diseases. Switching gears a little bit to metabolic syndrome, it still includes the fatty liver, of course, but now we can take things like just the so-called apple versus pear configuration of visceral to subcutaneous fat. But with CT, of course, we go one step further. We can look at the liver, the muscle, the distribution of fat, and actually we've come up with a composite CT-based model that predicts metabolic syndrome based on CT. Predicts outcomes much better than the clinical metabolic syndrome definition, which is pretty crude. So I think going forward, this is something we can be defining on an image basis and detect folks that are at much higher risk sooner. Michael already talked about cancer cachexia. This is colorectal cancer, actually. Just looking at, again, muscle density alone in patients diagnosed at time 0 with non-metastatic colorectal cancer. So they don't have advanced disease, but you can see, not even taking into account the tumor, the density of their muscle really portends their outcome, and those with lower density muscle or myosteatosis do much poorer, whereas those with differing amounts of myopenia or muscle bulk, if you will, or cross-sectional area, there really isn't much difference, at least with colorectal cancer. So it's interesting. We tend to focus more again on muscle density, but there are some interesting interplays. You may have heard of the fat paradox, where actually those patients with more subcutaneous fat mixed in with low muscle density, with high muscle density, tend to do quite well, whereas those with less subcutaneous fat but low muscle density, that portends a much poorer prognosis, and that kind of goes along with the so-called fat paradox. And then lastly, the last topic is we're really interested in using these CT biomarkers in a composite model that the output being one's biological or effective age relative to their chronological age, which can, of course, differ. And again, the things driving this, muscle density, aortic calcium score, and then the third one is visceral fat density, not amount, but density. So it's interesting how density really plays a major role in some of these models. We can show this in an individual. You can derive a nomogram to get this biological age, but just looking at it schematically, basically you want to be not one of these red dots where your biological age by the CT model is greater than your chronological age. You want to be below this diagonal line, one of the green dots, where your biological age is effectively, younger than your chronological age. And that really plays out. It's pretty amazing how if you're in the top quartile, your 20 plus year survival might be as high as 90%. If you're in the lower quartile, you can see it goes down to about maybe 15%. And this is even controlling for chronological age, where we're not just, that's not really driving it. So it's pretty remarkable that CT, I think, can really determine one's health when taken at this sort of comprehensive composite model level. Pretty much everything I've said applies that I've shown you in the abdomen. We can apply and are now applying to chest. We typically use non-contrast chest CT, which there's a lot of, so a lot of raw material there as well. A couple of final points. We're expanding beyond UW to many US-based sites, as well as sites across the world and every continent right now except for Antarctica. And we now have over a million unique patients. And so we're basically looking at racial, ethnic, geographic impact and trying to come up with more generalizable models that take into account one's specific demographics. And just in a quick example of that, we've compared a cohort of Black Kenyan patients to Black and white US populations. And there's some interesting things. Some things like you can see kidney volume here, SAT area or subcutaneous fat area, muscle area are driven more apparently by geography, with US populations, whether Black or white, being relatively similar, and this Kenyan African population being quite different. So geography seems to be driving this. In other times that we see where it seems to be more racially driven, interestingly, with spleen volume. And then there are other times where both race and geography seem to play a role, where there's clear differences between things like aortic calcification. We've also looked at socioeconomic disadvantage. And if you look at these key measures, again, aortic calcification, muscle density, by socioeconomic disadvantage, the measures get worse as you're more disadvantaged or living in an area of socioeconomic disadvantage. And this really plays out in two ways, because at the same level, at the same score, those in a worse, more socioeconomic disadvantage have a poorer outcome. So it's a bit of a double whammy. They have poorer measures, but at the same measure, they do worse as well. So in summary, I just tried to give a quick overview of some of the things we're working on. Obviously, we're really excited about the potential of using this opportunistic data, especially in these composite models, which we're finding really exceeds the performance of the best clinical predictors. And if we as radiologists don't capitalize on this and take advantage of this, I guarantee others will. So I'd really urge us to try to get the most out of this. Thank you very much.
Thank you so much for that fantastic talk, Dr. Pickard. One question I have for you is, you're showing, all this incredible data and results across so many different applications and biomarkers. Can you speak to your experience with trying to push forward your work to clinicians outside of radiology a little bit more?
Yeah, I didn't have time to get into that. It's actually, engaging our primary care stakeholders, I think is a really important next step, but it's been really challenging. I can just give a quick anecdote. About a decade ago, we unsuccessfully tried to incorporate opportunistic osteoporosis screening, where we basically were going to have a simple EMR-based drop-down order add-on for any patient over a certain age, say 65, that hadn't had their BMD screening. It would have asked, do you want to add that on? You're getting a CT anyway, it's free. We probably wouldn't have charged for it. We're doing that for CTC screening for free. We've been doing that for years with a DEXA equivalent hip T-score. But remarkably, even though we thought it was a no-brainer, they just felt, no, that sounds too complicated. But I think now as we revisit this with AI, this was the pre-AI era, I think the awareness is growing, and hopefully they'll see if we can show the clear value that's being added, and not do it in a way that's burdening them or adding to their workload, but making them work more efficiently. I think that is the next step, and doing some of these intervention trials will be important. We've kind of focused to date on retrospective to try to really see what the value is potentially, but I think that's a great point. We have to really engage our primary care stakeholders.
Excellent, thank you so much. We're next going to hear from Dr. Ross Felice of MedStar Georgetown University Hospital. He's a professor of radiology and chief of imaging informatics. He'll be speaking about coronary artery calcium and bone mineral density. And I'm really looking forward to Dr. Felice's presentation, given the importance of coronary calcium or CAC quantification. CAC is an imaging biomarker that's the strongest predictor of cardiovascular risk in asymptomatic individuals. And this data is embedded in millions of CTs that image through the heart, including routine chest CT, CT-PE, and lung cancer screening CT, in addition to gated CT of the coronary arteries. Bone mineral density is, another amazing imaging biomarker for the diagnosis of osteopenia and osteoporosis, driving treatment decisions. So really looking forward to your talk, Dr. Felice.
Thanks so much, Kirti, and thanks to everyone for having me. So yeah, I will talk a little bit more about the clinical application, or as we're trying to roll these out. Perry, I think, set the stage wonderfully with good background in opportunistic screening, and I'll talk a little bit about these two algorithms in particular, but I'll also talk about how MedStar Health is trying to actually roll this out clinically and use it. So coronary artery calcium scoring, I think many people are familiar with this, but it's really a very powerful non-invasive marker of coronary artery disease. And so this, the Agatston score you get in your heart can be very helpful in stratifying patients based on risk as to those who might benefit from therapy. And the therapies we have most often are going to be very simple and cheap oral statins that can make a big impact on morbidity and mortality for certain strata of patients. Historically, this has been a little problematic because it's required special dedicated exams to get these coronary artery scores, right? So it would have to be gated, ECG gated CTs. You'd have to schedule those separately. They require dedicated resources that not every entity might have. And so we found that these were not used nearly as much as our cardiologists would have liked. They can be somewhat time intensive, again, as a separate scan, and you'd have to do manual or sometimes semi-automated segmentation to get the score. So again, the penetration was just not as good as we were hoping for. But now in the era of AI, we have ways to get these scores from routine non-gated scans very reliably. This is a paper that I was a part of where we basically built a model that we think performs very well. Our model certainly is not the only one. There are many companies and researchers doing this, so it doesn't have to be any particular model. I think there are a lot of good ones out there. But this was back in 2021, we published this paper, and the performance then was quite good, but this has improved quite a bit since. And so we really feel like the AI application to non-gated CTs that might have some of that cardiac motion really is essentially equivocal to those of the gated scores. Again, so this is an example of what our model looks like. It's on non-gated scans, so any kind of routine scans. Again, in the spirit of opportunistic screening, you're getting this information for free because patients come in for their lung cancer screening CT or some other chest workup, and you can get the CAC score for free. A lot of the statistical analyses are done at an Agatston score of 100, and that's a really important threshold for those that don't know. The Agatston score of 100 is often where people will consider starting some kind of therapy, usually a statin. And the reason being is that the studies that have happened to date show that statin therapy below an Agatston score of 100 has really very little difference or impact on morbidity and mortality. But beyond 100, that's the threshold where you really see those survival curves widen and where statin therapy could have a big impact. There are other risk factors that are taken into account. There's certainly more complex models like the MESA model and other things. And so if you have other risk factors, there may be reason to start therapy sooner or at a lower score. But generally speaking, it's an important threshold that most people use as a rule of thumb. These images are from our institution, and so it's just a side-by-side showing the coronary artery calcium on the left and the segmentation of that calcium on the right. And I like to show it because it shows that the CAC scoring is pretty good. You can see it highlights the calcium in the coronary artery there. And again, this is a model from 2021, so things are much better now. But does a nice job of getting the coronary artery calcium. It intelligently avoids things like valvular calcium. You can see here a little bit of aortic valve calcium that should appropriately not be included in the CAC score. But I also like to show this because it's not perfect, right? There are a few dots that occur in places where there is no coronary artery calcium, although most of it is pretty good. And what I like about this is that what I like about this test, generally speaking, is that you really don't need to be perfect, right? The idea is you want to get people in the appropriate risk strata, and if your CAC score based on AI is off by 2 or 3, that's not going to make a huge difference in terms of where someone would be. If their CAC score on a gated scan is 350 and you give them a score of 340 on your non-gated study, they're still in the right area of where they should get therapy. And so I think it's very unlikely that these small differences are going to have any substantial impact on patient care. And this is what we show our radiologists. So we use this still as a supervised model. These images are sent to PAC so they can review these. They don't need to sit there and like segment everything out and make sure that, add up the numbers and make sure the numbers are correct. It's mostly to make sure that there's not some wild inaccuracy. In the early versions of this model, we would see some instances where it might pick up pacemaker leads or other unusual things. And so then we would just disregard the results and not use that. But that's pretty rare. But it is just a good validation check. In the very early days, this is what we did when we were working this up. Now, when we first deployed this, we were a little hesitant to deploy this widely for a bunch of different reasons, but largely because when we talked to our cardiologists, who we actually have a very good relationship, and I'll talk about this a little bit as we talk about the plans for deployment system-wide, they were really nervous because our cardiologists, probably like a lot of other folks out there, have a lot of patients, have very busy clinics, and really not a lot of room for extra referrals. And so they were worried if we moved this into the system-wide, that they would get swamped with people who needed to get their CAC addressed. And I'll talk about how we will address that going forward, because I think it really is an appropriate concern, but I think it's easily addressed. So initially what we did is we limited this to just a couple of our hospitals. We had a select group of radiologists that were participating, and when the scores got sent to PACs, they would review them just like I said. If they agreed with the review, they could just do one single click in a PowerScribe to pull up our CAC template. It would automatically put the score into the template, as you can see here, and then we gave a blurb here that sort of described what we thought about this particular score, whether it was 0 or not 0, and give a little bit of description about what we believe that might mean, what you might do with this, and what the limitations might be. And then in the early days of this, we actually did like a very labor-intensive project where we were trying to make sure we closed the loop with all the patients we identified that we felt were high risk. So what we didn't want to do was put these scores into reports and then, potentially identify someone that could be really problematic or high risk and not give them a way to be seen or be evaluated. So initially what we did is I had a research physician working with me, so we had a little bit of a labor pool. We looked at 2 of our hospitals, patients who had non-contrast chest CTs and who were 30 years or over. Again, it was supervised reports, and the inclusion criteria I'm listing here basically is our attempt to try and find patients who are at the highest risk, who are basically completely naive to the fact that they have coronary artery calcium. So it's CAC scores over 100 or higher, again, that important threshold, and again, those patients who have substantive calcium, relatively young, and we have no record of them ever seeing a cardiologist or being on a statin. So to our knowledge, they probably don't know that they have this coronary artery calcium, and certainly to our knowledge, they're not being treated for it. When we got those patients, every couple of weeks or so, we would get together, look at the patients. We had an algorithm that would go through all the different patients and query our electronic health record for the related clinical parameters. So we would use an automated system to get all that data. We would get all of the information to screen them by those inclusion criteria, and also all of the parameters that go into calculating a MESA score, which there's about 10 parameters, including things like family history, smoking history, what your cholesterol is, etc. We couldn't get those for everybody, but if we had all of those parameters for any of our patients, it was usually like 20 to 30% of them, we could calculate the MESA score and provide a risk percentage for those patients, the risk that they might have an event within 10 years. And then we actually called all of those patients individually and described what we found and gave them an opportunity to be referred to our cardiology group. This is a busy slide from a presentation that we did at RSNA, but the point here, what this is trying to describe is what happened to all the patients we saw. And if you look in the lower left, there was over 5,000 patients who we screened during this pilot period of over a couple of years. Out of those 5,000 patients, only a couple of hundred actually fell into those really high risk inclusion criteria based on our automatic query. We contacted around 88 of those. Multiple of those did not want to be referred for many reasons. Some of the patients had, cancer that was, end of life sort of cancer. We're a big cancer institution. Some patients had other cardiologists they were seen elsewhere. Some patients turned out that they were on statins or other reasons why we may not want to refer them. And we ended up only referring 32 of those patients to cardiology. So this was very helpful in reassuring our cardiology group that they were not going to get bombarded with tons of high-risk patients. Now, this is a very select group that is very high risk. There are certainly many other patients that might be candidates for some type of referral, right? If you remember the threshold we're using of 100, well, if you're a 40-year-old man and you have a CAC score of 1, that's actually quite high risk because you really shouldn't have any coronary artery calcium at that age as opposed to someone who's, 90. And so our study did not, there still is many other groups of patients that you could consider for potential referral, but I'll talk about how we're going to address that at MedStar going forward. So this is sort of I'll try and describe our plan for our system-wide deployment. We were pretty close to doing this. At the end of the day, it wasn't scalable to call every patient. I mean, that's just not a practical thing, even if you're limiting to those very high-risk patients. We do about 30,000 non-con chest CTs every year at MedStar. It's just not something we felt we could do. We wanted to come up with a plan where we could ideally give every patient and their referring providers at least an opportunity to access some educational material and guidance so they would kind of know what to do with this information without alarming them unnecessarily. We did not want to overwhelm our very saturated cardiology practice, especially for patients that don't need complex management, just need to be put on a statin perhaps, or maybe nothing. Again, did not want to alarm the patients, but we also wanted to have a method to sort of close the loop and mitigate any risk that would come up with this. So for example, if we say someone has a very high risk CAC score or CAC profile, and then we don't offer any way for them to be seen and they die of a heart attack, there was some concern from our risk and legal group that could be problematic. We got everyone together with cardiology, radiology, and primary care. And this is very important because our primary care teams, they're actually very competent at managing this stuff. And especially because we made an effort to go out to all of their sort of leadership and collaborative groups to give them guidance on how to manage this. So that's how we mitigated the concern from cardiology about getting too many referrals. We got some of our patient communication experts from our MedStar Institute of Innovation, and we had legal and risk leadership involved at the highest levels to make sure we were sort of doing this appropriately and mitigating any risks that might come along with it. Again, we did a lot of educational stuff to the primary care groups. They think they can manage around 90% of these with the knowledge that they have, so that was a big relief to cardiology. And then we developed some stratified language that I'll show you in a second here to put in our reports. And we're going to track those that are high risk in an incidental finding management system that's about to be deployed at MedStar. And again, patient educational material will hopefully be in our patient portal. This is what the language looks like. So there's 6 strata. You can see for 0, we will give, and this is not the full text. I couldn't include everything here, but this includes at least the meat of it. For 0, we'll of course describe that 0. Then we also describe some of the limitations with giving some a score of 0. We will then, if they have less than 100 of a CAC score, but their Hoff model, which is a simplistic version of MESA that looks at their age and ethnicity, if their risk based on Hoff is relatively low, we will put that in the lower threshold strata. If it's high, so that would be someone who like maybe a 40-year-old person with a CAC score of 1. We'll put that in a higher stratification that might be referred for cardiology referral. And then it goes up from there, from 1 to 300, 3 to 1,000, and 1,000 above. And we put some language in there that describes, that sort of escalates the severity of what this might mean to, because at the highest levels, you may actually want to alarm the patient a little bit to make sure they get seen. So that's the coronary artery calcium stuff. And again, we're planning to go live pretty soon with that at MedStar. I'm very excited about that because I think we could have a pretty big impact on our patient population. But that's hopefully gives people an example of how we're doing that in a very multidisciplinary way. I'm just going to spend a couple of minutes on bone mineral density because we're a lot further behind on that than cardiology, but we're doing something very similar with this for bone mineral density, which Perry talked about very nicely just a minute ago. This is another one of those entities that we see a ton of, right? There's a ton of people with osteoporosis and osteopenia, and it actually has a huge morbidity and mortality beyond what I really knew until I got into the field of opportunistic screening. But it's something that we can treat and prevent. And so I think it's another one of those very important things that we should be screening patients for and getting them referred for treatment. Similarly here, we're doing sort of a multidisciplinary approach. So we have orthopedic surgery involved, primary care, of course, will be very important. And then we have several bone health clinics around the system that will serve as referral sites for those patients that need it. And this is what our text will look like. The algorithm we're using is a binary algorithm, which just tries to find those that are associated with osteopenia and osteoporosis. It will give some language, sort of descriptive language like these as well, where you could, of course, further confirm this as needed. And then we may include some referral information to our bone health clinics in here as well. And this will also be supervised, by the way. So you'll get some segmentation and description of what this looks like in PAC, so the radiologist can review that and make sure that it makes sense. Okay, so thank you so much, Kirti.
Thank you so much for that remarkable presentation, Dr. Felice. I have a question in terms of, I think the data that you have for CAC is really exceptional and really exciting to see how that you're pushing that into clinical implementation. What proportion of the CT scans that are ongoing at your center are being analyzed for that currently? And are you doing any QA kind of measures for those now, or is that given kind of prior results, are you just trusting that data is accurate?
Yeah, I mean, we do trust it basically is accurate. I mean, with the supervision we make it very easy for the physicians to supervise it. So I don't think there's any no one's really expressed any concern that it's inaccurate. We have been, through our pilot, it's probably about 10 to 20% of the MedStar are just CTs. But again, the plan is to go system-wide, which for us is about 30,000 a year. Amazing.
Thank you so much. Really appreciate that. Our final speaker is Dr. Søren Brunek of the University of Copenhagen. He is a professor in the Department of Public Health as well as Disease Systems Biology program. He's the head of section of Health Data Science and AI. And the title for his talk is Epidemiologic and Predictive Perspective, EMR-based Tools for Opportunistic Screening. I'm thrilled that Dr. Brunek accepted my invitation to speak. In radiology, it can be easy to remain siloed within our specialty, even though prior innovations in our field have transformed medicine. And he'll provide the critical epidemiology perspective on how to provide evidence to support widespread implementation of opportunistic screening using AI, especially leveraging large EMR data sets. Thank you so much. I'm looking forward to your presentation.
Yes, thank you very much for the opportunity here and the invitation. So this talk will be on reusing EMR data to predict new hitherto undetected diseases. So typically in screening, of course, we would like to spot diseases as early as possible using known risk factors of various kinds. So what we and others have started to do some 10 years ago is essentially to use the entire life course trajectory of diseases. That depends, of course, on how far back the data go. I come from Denmark, where we actually have kept data for almost 50 years in terms of diagnosis. So for a guy like me, the diagnoses are kept 50 years back, and we are using these data to predict new diseases and maybe also limit the resources you use on radiology. And you can, of course, imagine not only using diagnosis, but also prescription trajectories, lab value trajectories, clinical text trajectories, and also image trajectories. So many modalities can come in play. And the idea is, in some sense, to acknowledge that the route you take towards the disease can decide on the severity of the disease. If you reach a certain diagnosis in one way, you might have a lower risk of dying soon. And if you reach it in another way, you might have a higher risk. And these methods, the AI methods that we use to analyze the life course trajectories, they can pick these patterns up. So this is a peep at how these data typically look like when you take data from an entire country. Of course, we are a pretty small country, but here you see inpatients, outpatients, and emergency room patients, and then you see color-coded diseases as a function of age, females to the left and males to the right, and you see all the pregnancy-related diagnoses in green. In brown, chapter 2 in ICD is close to the x-axis, and you see it kicks in earlier for females due to breast cancer than it does for males, where it's dominated by prostate cancer. So these millions of trajectories can be used to create prediction tools that can again be used to screen for new diseases. Here's another illustration of the same 8 different cancers, and you see what is overrepresented years before, up to 10 years before the first cancer diagnosis appears. So we, as I said, plug these data, and this is the simplest version where we just take diagnoses, plug them into deep learning architectures, typically transformers. Here's an illustration from a pancreatic cancer paper that we also made together with Dr. Rosenthal some years ago. There was the first attempt to use 6 million patients, cases, and controls, 24,000 cases and around 6 million controls to train a discriminatory algorithm that then can be validated, but also tested, for example, in another country. And we actually used data from the Veteran Affairs Administration in the US to test the algorithm. When you predict new diseases into the future, you can of course do it at different time horizons, 3 months, 6 months, or 36 months and 60 months. When you measure the performance, it's not surprising, for example, when you predict pancreatic cancer, that it's harder to predict 60 years than 36 months, sort of 60 months than 36 months into the future, and very easy with 3 months. But you can sort of determine how many false positives you will find from your screening in this way. So now we use many modalities in the same sort of transformer architecture. So we use primary care data and secondary care and tertiary care data in the same combined algorithm. And this is from a review that was published 2 years ago. And there's of course not really limits to this. You can use any type of life course data that you will have on the patients. And you can also set this up to run clinical trials in a prospective manner. In a very recent paper last year, we actually modified the ChatGPT-2 architecture, not to predict the next in a sentence, but actually to predict the next disease. And not just for one disease, like in the work on pancreatic cancer, but in this architecture, we actually handled 1,000 diseases in one go. We also predicted the time to event. There's some modifications in red here to the ChatGPT-2 architecture, and we will not go into the details, but it's quite interesting that actually dealing with many diseases in one go seems to allow the model to pick up many of the correlations in terms of how one disease increase the risk of another in a longitudinal fashion. So it's a little bit like when you look at text. Here's an English word where we, as English-speaking people, can see what is an H and what is an A, and that can be compared to the situation with diseases. Some diseases can both be a risk factor for other diseases or can be a complication to another disease. For example, atrial fibrillation is an example of a disease that both can be a risk factor but also a complication to a disease. And these transformer architecture can pick these correlations up. This is essentially what's happening. If I switch to another word, the word that is written here in Danish, most of you would not really be able to see what is an H and what is an A. But that's of course because you haven't learned the correlations between the letters in Danish. So you really need to adapt these trained architectures to the population you would like to look at. We can also go into the text of the patient records and, for example, look for the order in which symptoms appear in the text and use old school text mining or large language models to sort of model the temporal patterns in these symptoms and then use them to make a more rich symptom spectrum than what is actually coded in the structured fields in the patient records. So life course disease trajectories is a simple way of reusing existing routine care data. We published the first paper in 2014 where we used, on the y-axis you have how many years of data we include in the model, and we used around 15 years of data in that study from 2014. Up in the right corner, Placido et al., we used 42 years of data, a paper from 2023. You see in yellow, further down to the x-axis, a study where 50 million patients were used. That was UK data, not so many years, but some of these data are diagnosis trajectories, others are prescription trajectories or claims data. So multimodal models can be made and then used to enrich for high-risk patients that you would like to spend radiology resources on. So finally, I want to mention that when you look around the world in different countries, and here's the United Nations and also an OECD survey on how advanced the digital government is in different countries, it's clear that it's the single payer countries like Denmark or Estonia or Singapore or Korea that really have kept their data for many years so that you can use the life course data. But this is just a matter of time because different countries are no longer throwing health data away, but actually are keeping them instead and then enabling making these deep learning architectures that actually learn from from the live course in the way that I have described. So acknowledgement here, and thank you for your attention and again for the invitation.
Thank you so much for that remarkable presentation, Dr. Bruneck. I'm wondering, have you considered synergizing clinical and radiology data in your models? Do you include radiology reports, or have you thought about imaging itself?
Yeah, we actually also make deep learning analysis of videos. We recently published an angiography paper with 50,000 angiographies, and that was sort of a typical imaging paper where we just used one data modality. But we are now combining these approaches with the traditional EMR data to increase the performance.
Perfect. We'll definitely be interested to see how that goes, because I feel like there's so much of interest that can happen when you combine those two data sources together that are very rich.
Yeah. Thank you. Yeah.
Perfect. Okay, so now that we've had a comprehensive overview of a number of topics related to opportunistic screening, we're going to start a panel discussion. I am going to be monitoring the chat in case we have any questions from our audience. And I'll say that so far, we had one audience member say that today, Dr. Pickart, you were cited by someone from our audience. So that's a nice shout out. But I'm going to start out with a couple of questions that I have prepared. But again, please do post any questions that you have from the audience. So the first question I have is, how much of our opportunistic screening that we've seen today and that's been published has been analysis of CT images? Have any of you considered other modalities such as MRI, ultrasound, or X-ray? And what about other areas of the body besides chest and abdomen? And anyone can go ahead and speak forward.
I mean, I can speak a little bit to the MR question, because we, of course, use MR in high-risk screening. That the challenge with MR biomarkers is that MR is just a really difficult modality computationally. CT has this careful calibration of the Hounsfield scale that's done daily. MR is a relative scale, and so you get wide variations in the units. And with all the different sequences and motion artifacts and things like that, it's just really difficult to extract stable signals. Now, at a population scale, yeah, you can do this kind of thing. But when you want to talk about building systems that will drive individual risk assessments, that kind of variability is hard. Making progress in it, yes, but it's just a difficult task.
Yeah, and I would add, since we're all mostly body imagers, that there is more potential with MR in neuro and MSK applications, and certainly things like brain age have been used. You know, parts of the body that aren't moving, MR has at least the advantage of having some stability there to improve image quality. But yeah, nothing matches CT. Although, you know, I would say radiographs are also a pretty interesting source of, you know, chest X-rays in particular. I was involved in one study that showed that you could use a chest X-ray to predict diabetes pretty well. Of course, those tend to be more black box type, although you can see the saliency maps and see what it's looking at and stuff, but it's not nearly as explainable as we can make CT. So I think it's less appealing in that sense too.
It's really interesting. This question I'm going to pose to Dr. Felice. So for CAC, what's interesting about that to me is that imaging biomarker has been recognized enough that people undergo CT specifically for that imaging biomarker, and you're trying to do it opportunistically as well. And you can probably say the same for bone mineral density, that some people are going, you know, for that imaging test specifically. Do you see this happening for other imaging biomarkers that we've kind of discussed today, or that you've thought of? It's kind of an interesting dynamic where we do such a good job that maybe, you know, people decide electively to kind of go and get screened for that particular biomarker.
Yeah, I don't know. I mean, for hepatic steatosis, there are ways to quantify that, an ultrasound and MRI, right? So you could do that. You know, that's the only one I can think of in particular. I think it'd be nice to get to the point where you don't really need to do those to confirm them. I mean, I think it's fine. Like, I'm not trying to compete with them or, like, you know, say that you can do it if there's some concern that the AI, you know, opportunistic algorithms aren't giving a good value. But I think the hope is, you know, it's just not going to be possible probably to get everybody who qualifies for those exams and for those specific exams. So I think we have to be careful with who we send for those specific confirmation exams.
I think that's very interesting. And then I think the next kind of question I have is for Dr. Bruneck. So, you're talking about these large EMR data sets. They're going back, you said 50 years. That's an enormous amount of data when you're talking about millions of patients. How are you, from the informatics side, kind of dealing with that volume of data and managing that? And how does that, I know it's different in Denmark compared to the United States, but, it seems like it would be very difficult to kind of deal with that volume of data, especially when you're talking about all the clinical notes and different types of data that could be available for each patient.
Yeah, that's is an important question. I would say that a lot of the sort of classical EMR data, they are maybe, we have many modalities, but they are not sort of taking up a lot of storage space or something like that compared to image data. So even if we have millions of patients, these data are not so capacity requiring. But of course, we need GPU capacity, and we had Jensen Huang recently inaugurating a very large $100 million machine here. So we have capacity also to train really large models. We can maybe not compete with the large tech companies, but I mean, these infrastructures are being built, and we can manage actually handling population-wide data.
Excellent. All right, my next question is about funding for these projects. So I'm kind of thinking about, all of these projects are interesting and exciting, and thinking about what it's going to take to push them kind of more into the implementation stage more widely. How do each of you perceive funding kind of for these projects at this research stage? How do you think it's being perceived? Have you been successful, or do you think that it's challenging to kind of convince people to fund these sorts of projects? I'll start with Dr. Rosenthal.
Sure. I'll say that it's very much about phase. So right now, the early phase projects where you're trying to do local model building and such, it really depends on your institutional resources, because you need to have some GPU time, which has gotten quite expensive if you're paying for it yourself. But if your institution has a program, then you can go and build a model from your institutional data, no problem, and you don't really need an external grant. Once you start talking about validation, large retrospective cohorts, multi-institutional, then the NIH has been a good source of funding in the past. It's gotten a little complicated, but screening has still, at least in my experience, still been something that has been sought after. The foundations right now, at least in the pancreas domain, and I think in other domains, are really stepping up, and that's a great place to go look for money right now. The real challenge is going to be when we start trying to do this prospectively, because we're going to need big multi-institutional funding, and this has traditionally been the role of these big cooperative groups like ECOG and such, and figuring out if Alliance and ECOG are going to be ready to manage these big AI projects. It's going to be an interesting challenge. They certainly have the growth expertise in the past, but it's not an area that they've necessarily done this kind of activity before.
I mean, it is interesting to think about what a prospective project would look like, because, if you're talking about screening, you might need a very large number of patients that you'd have to enroll, right, and follow. So,
yes, I mean, we estimated in our high-risk group, for example, it would cost somewhere around $40 or $50 million to really do a thorough prospective evaluation of some of the questions we're asking, and that's outside of the usual NCI grant portfolio. You're really talking about having to walk in with one of the big consortia to even have consideration there.
Perfect. Does anyone else want to jump in on that question about funding?
Yeah, I can just add, when we not moving away from the oncologic side of things, but more to the cardiometabolic we've had pretty limited success, in fact, almost no success with external funding for some of these large-scale retrospective studies. Now, fortunately, they actually don't require a lot of funding as long as you have the infrastructure. You can do pretty massive studies with almost on a shoestring. And, that's why, folks like Ross has been able to join our consortium, places that have the know-how to retrospectively, just dig up all this information at a place that I think maybe values research to allow it to happen. Other places, they'll charge you per scan or something. But I think what he was talking about specifically with the prospective intervention trials that I think are going to be so important, those are expensive. And like Michael said, with any prospective trial, I think those to prove that the interventions make a difference, I think will require funding for sure. And I think that'll be more of a palatable proposal to some of these agencies than retrospective data review, which has not, in our experience, like I said, has not been a very successful funding compared to other things I've done. So.
I could add a European perspective, because these live course data, they are existing in many countries in Europe. So we are maybe having more legal challenges than we have funding challenges, because there are many health data science calls from the EU and also nationally. And a new development in Europe is the so-called European Health Data Space that will make sort of the legal hindrances and barriers smaller for federated analysis of data from many countries. I mean, in the US, you have fewer of these barriers, even if it's not trivial. But in Europe, we have many more of these legal barriers. And now we can look into a situation where at least some of them will be removed.
All right, so we actually have a question in the chat. So one of our audience members has asked, I'm conducting a study in my country for opportunistic screening for osteoporosis using L1 for both contrast and non-contrast CT. And they're just requesting any advice from the panel.
Advice in terms of how to adjust for the effective IV contrast specifically? Or?
I think it's just open. So I feel like either question. So maybe you could handle if you could respond to maybe the contrast versus non-contrast.
Sure. And also just to say L1, I mean, we've looked at every level, and you can use any level you want. But the reason I know we've gone with L1 is because it's there on most chest and abdominal scans. It's easy to find as the first non-rib bearing. And it actually had the best performance, slightly better than other levels for predicting future fractures. So I agree with the L1. And it is pretty easy. There are publications available that allow for the adjustment for the effective IV contrast. It's not perfect, but for opportunistic screening purposes, you can lump those data together, and that's what we tend to do with most of these biomarkers. With a few exceptions, you can adjust for IV contrast. So, if that's the question.
All right, that's great. My next question is in terms of the future of opportunistic screening in radiology. Do you think that this is something that can be billed for? I think we've talked a lot about maybe this just being something free that will kind of happen on the side, and that way, I imagine institutions will be absorbing this cost, or at least research groups will be having to kind of pay for some of these infrastructure costs. Dr. Felice, I know that you do that, at your institution currently. How is that cost borne out in terms of coronary calcium and for bone mineral density?
Yeah, I mean, for us, it's sort of an easy answer because we help develop them, so we have a license to use them. So there's really no cost other than some, pretty basic like server maintenance costs. It doesn't require GPUs for inference, so the cost is very, very low. Even if you're going out to buy it commercially, though, if you take CAC, for example, there's enough competition out there that I don't think the cost is going to be terribly high to get a decent algorithm. And there's all sorts of ways to show some of the ROI, whether it's patients coming back for follow-up visits, further confirmation scans, even if you want to look at it from like medical legal risk, are you preventing that one lawsuit from someone? We've had a few anecdotal situations where people will come back and say, hey, I'm on a statin now, I know I'm at risk, and by the way, my CT from 5 years ago, there was a bunch of coronary artery calcium, why did you tell me? So I think there's plenty of ways to, to manage the cost. There are tissue, I can't claim to be a CPT billing expert, but there are tissue characterization AI category 3 codes, I think, that you can use. They're pretty broad. There's at least one for ultrasound and CT that I'm aware of because we use it for thyroid ultrasound as well as some of the CT algorithms. Whether reimbursement is going to follow those, I know some institutions have had some success there, but I actually think there will be a future where there will be some reimbursement associated with those. I don't really see why not. I don't know exactly what the timeline will be. So there may be a way to actually directly pay for these algorithms as well.
And if I can follow on to that, I agree that this is the way that things are kind of falling together right now. But I think until there is explicit reimbursement or some kind of explicit funding across the enterprises, this is going to be a relative starvation state for these methods. Right? No one's going to go build companies to make the most amazing screening algorithms for us if they can never get paid, if there are no economics behind it, other than people like us who have things in the patient's interest. But when we talk about needing to scale to analyzing 100 million CTs every year, that's going to cost money as these algorithms get more expensive. And so we will have to pay data charges at the level of the national endeavor. And so we're going to have to figure out how to get paid, and whether that's through grants to the hospitals or through per scan charges, I don't know, but it needs to happen to keep the ecosystem alive.
Yeah, I think that's definitely true. Another thought I have is in terms of getting buy-in. We've been talking about ordering providers, talking about our cardiology colleagues, talking about primary care providers. What about patients? Do we kind of need to publicize these tools and techniques to patients, similar to how patients were made aware of and could ask for 3D mammography, for example, or tomo, and patients kind of knew that there was like some difference there between 2D and 3D. And I don't know if you guys have any thoughts on what would be the best way of kind of doing some patient outreach in terms of saying, these are some interesting things, additional kind of benefits you can get from your imaging or from your data, your patient data, in the case of Dr. Brunak. Maybe I'll, go ahead, sorry.
I think that the patients are super important in this game, and their engagement, and the patient organizations, they are of course also important stakeholders, and I think they could maybe also contribute to funding infrastructures in various ways. I would like to mention metadata and ontologies for these types of data, because it gets increasingly complex with procedure codes and diagnosis codes changing over the years when you have image data from many years. So some of the boring things in this area, where we really need to sort the data when patients with multimorbidities have had 10 or 15 diseases and a lot of imaging, sorting all the data in ways where they actually can be used in deep learning frameworks and so on. It's not so easy. So annotating the data and terminologies and metadata, I think that's also important, and I think the patients could benefit from having a say in those areas.
Yeah, I think that's really interesting. And, Dr. Felice, you actually had interacted directly. I feel like part of that research study you mentioned, you guys reached out directly to patients. Is that correct? And so you're able to hear maybe from them directly what they thought about the technology that you were implementing?
Yeah, I can only give you really anecdotal, experience, but I can tell you there was concern when we actually told, some of the folks in MedStar that we were directly to patients. They were worried that maybe we didn't have the right to, that they give us the right permissions, that they sign the right consent documents, all that other stuff. And at the end of the day, they decided it was okay. I can tell you, nearly universally, patients were extremely happy to hear from us. I mean, they thought it was wonderful that we were telling them additional information, that we were sort of offering them advice and education on that thing. And so I think you'll find very few patients that are somehow upset about it. I mean, we had a couple of patients that, sort of felt like it was overwhelming because they had so many other things going on, whether it was cancer, transplant, like whatever else, but they were not, upset to know. It was just a matter of prioritization. So I really think patients will be very receptive to this.
Yeah, I would echo that too. That I think patients are really, it's an interesting idea to have patients drive this. And it's somewhat analogous to our virtual colonoscopy experience, where we constantly had patients telling us every day, that they went to their doctor wanting a virtual colonoscopy, but their doctor told them it's experimental. Why don't you get a colonoscopy instead? Or what, I think patients definitely want this information. And if they don't, they can opt out, obviously, as well. But any friend or family that has a CT scan that I know, they all want their biological age, and they want to know if they have calcium, and they want to know what their bone mineral density is. They want to know what their visceral to sub-Q fat ratio. I think patients are pretty savvy, and they know the value of the wellness angle here. And if you don't want that information, I think, like I said, you can opt out. So we don't have to force it on anyone. But the patients will definitely want. The majority, I agree, will, and that might be an interesting the primary care obstacle that we're kind of facing right now.
Were you saying that sorry, go ahead.
If I can add on one prior experience, when surgical robotics was in its infancy, around the time I was doing my PhD, they had some really difficult times with the economics of getting surgical robots into hospitals. And then there was a moment when suddenly patients started to ask to have robotic surgeries for particular applications, particularly prostate and such. And all of a sudden it went from you couldn't make it economically viable to have a robot to you couldn't have a service that was doing that without having a robot. And that was when surgical robotics exploded and suddenly became economically viable. I wonder if that's going to happen here. We don't really have a solitary killer app in opportunistic screening yet, although many of the people on this call are certainly working on some awesome things. When that happens, maybe it's going to be the patients who say, no, you're going to be a good hospital if you have this, and then the CEOs will open the doors.
Yeah, I love that idea of thinking about, maybe I will have my abdominal CT at Hospital X where they do have all of these tools as an additional add-on rather than, the competing hospital across town. I think it's also interesting to think about that opting out, Dr. Pickard, because when it comes to these AI kind of algorithms and AI-driven studies and patient consent and thinking about all of those sorts of things, it would be interesting for this particular application how a patient would actually opt out if it's something that's just being done opportunistically. Maybe it would be something that would, that might put the onus on the ordering provider to have a discussion, or maybe when the technologist kind of greets the patient, it would be an additional thing that they would have to be asked. So I think that brings up other kind of questions, but some kind of food for thought for as this moves towards wider implementation. So I like thinking about that. And even though we think that might be a very small number of patients, I think good to think ahead of time about, how to address those patients.
Perhaps you could have them opt in, and therefore they'd have to make a positive action to get that information, as opposed to just unleashing it on everyone. But you're right, it is an interesting, I think it's important to think about that kind of angle, not to alienate or end up, forcing something on somebody that they're not interested in. So.
Yeah, I would agree to that, but we also have to realize that the multimorbidity is on the rise, and it's not just one disease separately from other diseases. So these approaches that deal with many different diseases, they will target a large part of the aging population. So that's of course not in all countries and in all population groups in a single country, but polypharmacy that goes with the multimorbidity is another problem that needs to be factored in here.
one thing that I think medicine, at least in the US, is maybe relatively advantaged to other AI, is that medicine in the US has a pretty good grip on privacy concerns, and generally has been respectful of people's privacy, whereas the AI tools that are out there right now that are constantly asking for your permission in like a million pop-up windows to use all of your data for everything, or maybe undermining their own future trust in doing so. So maybe the hospitals will be a place where we can maintain this trust relationship with the patients, have them feel comfortable that their data is not going to be sold off to the highest bidder through us as institutions, and then we can make advances where in other places it might be important.
All right, well, with that, I want to thank all of our speakers, Dr. Rosenthal, Dr. Pickart, Dr. Felice, and Dr. Brunac, for their insightful presentations and time. I also want to thank you, our audience, for taking the time to attend today's session. Thank you very much.
Thank you all.
Thank you.